scaphoid. There is congenital bipartite scaphoid also there. And here in patella, I explained that this congenital bipartite patella occurs at the supralateral aspect of knee joint. But in scaphoid, it occurs mainly through the waist at the middle, where the common site of fracture of scaphoid is there. In that particular site itself, the congenital deformity or condition occurs. And to define whether it's congenital or whether it's a fracture, we should go for the check X-ray of the normal hand, and then we can find it's a congenital. So the first thing we should keep in mind whether it's a congenital condition or not. And the second one is trauma. Second one we should keep in mind is trauma. It may be direct or indirect, whether we ask the patient whether there is any history of injury. Regarding pathological conditions also, regarding Chondromalacia patella, patellar tendonitis, iliotibial band syndrome, bursitis. In all these conditions, the history is important. Why? Because in prepatellar bursitis, the job may be housemaid. In infrapatellar bursitis, it may more commonly occur to priest, and so it's known as clergyman's knee. And sometimes this iliotibial band syndrome may occur to marathon runners, or who are doing cycling, or to aged patients. If this may happen to 50 plus patients also who are doing rickshaw pullers. In All India Institute of Ayurveda in Delhi, the most of the patient coming to OPD with iliotibial band syndrome is due to this rickshaw pulling. And here in our area, which is a hilly area, in this particular part, more patients come to us with a history of rubber tapping. They are walking uphill and down with weight. Males and females are affected above 50 age group, and that particular condition, that history may cause iliotibial band syndrome. And this Chondromalacia patella may occur at the age of 18 who are doing sports. It is more common in females, and it may occur at the age of 18. It may occur in males also due to patella alta condition. I will explain what is patella alta in the coming slides. This patella alta is due to high situated patella, and that particular condition, patella alta, may cause this Chondromalacia patella in the younger age group in males who are doing sports. And otherwise, it may occur above 20 to 35 age group, mainly in females who are walking downstairs or climbing down the hill. In such patients, this Chondromalacia patella may occur. And that particular patient definitely complains, now the patient is unable to climbing down or climbing downhill. And that particular history is of much importance regarding Chondromalacia patella. Regarding bursitis, I already explained. And in patellar tendonitis, I already explained that it may occur in between age group 15 to 30. It may already occurring in age group 15 to 30 who are doing sports activities, regular running, such activities, there is a chance of patellar tendonitis. And the hamstring tendonitis or hamstring tear may occur in middle distance runners, in 400 or 800 meter runners, or in footballers who are regularly doing this high power shots. In such conditions, there is a chance of hamstring tear or hamstring tendonitis. And that history taking is very much important in pathological condition. In trauma, definitely all of us know it's of utmost importance, but in pathological conditions also, that particular history taking is helps us in the diagnosis. And this trauma may be direct or indirect. Check whether there is a fusion or hemarthrosis. In ACL tear and in fracture, there will be hemarthrosis, but in meniscal tear, as it's avascular, there won't be hemarthrosis. So in ACL tear, immediately after the injury, within 1.5 to 2 hours, there will be swelling. But in meniscal injury, it may take 1 day, up to 1 day, half day to 1 day, it may take time to get the swelling. This is very much important. This is regarding infection, septic arthritis, as this is a very rare condition. The septic arthritis is a very rare condition, but there is a chance of septic arthritis in knee joint. If we miss the diagnosis for 1 day, then that joint will be affected. That means the patient is unable to do weight bearing. So definitely, whenever the patient comes to OPD without a history of injury, with severe pain, and the patient is unable to weight bear, and the patient is unable to do flexion and extension. The septic arthritis may occur at any joint. Hip is the most common site. It may occur in age group 5 to 10. mainly males. And also there is a chance of transient ischemic synovitis, which means this transient synovitis is differed from septic arthritis. It may also occur in age group 5 to 10 in male patients, followed by upper respiratory tract infection. Mainly right hip is affected. And to differentiate whether it's a septic arthritis or not, I will say one criteria called Koch's criteria. In Koch's criteria, what we are looking is, one is CRP, which is above 20. Second one is patient is unable to bear weight, or patient is unable to do the movements of that particular joint. Third one is fever, fever above 101.4, and the fourth one is raised ESR above 40. And sometimes fever may occur late, but all other three may occur at the time of septic arthritis itself. And in septic arthritis, immediate referral of patient to orthopedic surgeon is needed, and that patient's pus should be aspirated and synovectomy should be done with antibiotic cover. If we are referring the patient, or if the patient condition is diagnosed at the correct time, then that joint will be saved. Otherwise, if we wait for one day, that pain is very much severe, and due to this pus, the joint will be affected and the patient is unable to bear weight. As this is a rare condition, but we should not miss the septic arthritis. And this next one is neoplasia. It may be bone or soft tissue or hematological. This bone CA is very much common at the knee joint, mainly osteosarcoma, mainly in younger age group. And other conditions called osteoclastoma, which is more benign. Such conditions may also occur. So that definitely in a knee joint condition, if a younger patient come to us without any history of injury and pain, definitely we should go for radiological investigation with minimum hematological investigation. The hematological investigation in the beginning should be less. If there is increased CRP and ESR, then we shall go for another next stage of hematological investigations. But the first investigation, X-ray and basic hematological investigation should be checked as per the condition, not in all cases, as per the condition. I will explain one Ottawa rule of knee joint, in which the age group is in between 18 to 55. Age group is in between 18 to 55. Whether there is isolated tenderness at patella and at the proximal end of fibula, and the patient is unable to flex the knee joint up to 90 degrees, and the patient is not able to bear weight. That means the patient is not able to walk a distance of 4 steps. Limping can be advisable, but if the patient is not able to walk 4 steps even without limping, and in these 4 conditions, if the patient's age is between 18 and 55, definitely we should go for X-ray investigation. And if these 4 criteria are negative, then we can avoid X-ray in that particular knee joint injury. That is Ottawa rule of knee joint. I will explain it once more in the further slides. Just please keep in mind, if a young patient comes to us with pain or any deformity or any swelling, in such conditions, definitely we should go for basic radiological investigation and hematological investigation. But that these particular conditions are very rare, but we should not miss it. The biochemical consists of crystal arthropathy and gout and pseudo gout. And this pseudo gout is more common in knee joint. Pseudo gout is more common in knee joint. In all gouty patients, if the knee is affected, you can feel very much tenderness in the pes anserine bursa. Please note, this is a clinical finding. Whenever a patient comes to OPD with gout and knee joint is affected, there will be more tenderness at the pes anserine bursa. And this pseudo gout, the most common site is knee joint. Coming to endocrine, there may be diabetic Charcot's joint. And Charcot's joint means that particular joint is affected and it's degenerated, and the patient's weight bearing is not possible with that joint. And this particular condition, our prognosis is not much good. I saw one case of ankle Charcot's joint. Our prognosis is not good, and please keep in mind, this diabetic Charcot's joint, degenerative, most definitely osteoarthritis. Chondromalacia patella in knee joint is also of degenerative. The cartilage in between patellofemoral joint is affected in chondromalacia patella. We will see the clinical examination of chondromalacia patella in the coming slides. And another finding is vascular. This is hemophiliac hemarthrosis. This condition is also rare, but it may occur whenever a patient comes to us with monoarticular joint pain. Please keep in mind. Coming to inflammatory, as we all know, the autoimmune conditions, rheumatoid arthritis, psoriatic arthritis, reactive arthritis. The RA is rheumatoid arthritis and REA is reactive arthritis. Actually, this rheumatoid arthritis, as we all know, it's a systemic illness and it may affect multiple joints. Please keep in mind regarding ACR-Euler criteria. And this ACR-Euler criteria is for the diagnosis of rheumatoid arthritis with 0.6 is needed, and the criteria what we are checking is increased CRP, highly raised CRP and ESR. The second one is duration above 6 weeks, and third one is the small joints, 10 small joints must be affected, and such things should be noted in ACR-Euler criteria, updated ACR-Euler criteria for rheumatoid arthritis. And this rheumatoid arthritis may present with knee joint pain, with one knee joint pain. It may start with one knee joint pain. So that please keep in mind, there is a chance of presentation of one knee joint pain. There is a chance of rheumatoid arthritis, so that we can do the basic clinical examination and hematological investigation, in which we can see that there is increased CRP and ESR. And then if there is increased CRP and ESR nearly 100, CRP above 50, in such conditions, we will go for anti-CCP. Anti-CCP is the gold standard test for rheumatoid arthritis. RA factor is not the gold standard test for rheumatoid arthritis. For rheumatoid arthritis, definitely we should check anti-CCP, ACCP, and if ACCP is positive, then we can definitely confirm it as rheumatoid arthritis. Please note that there is a rare chance of presenting one knee joint pain as starting of rheumatoid arthritis. Next is psoriatic arthritis. As the psoriatic arthritis and reactive arthritis are spondyloarthropathies, and this in spondyloarthropathies, as we all know, the spine is also affected and there is multiple joints affected. And in psoriatic arthritis, there is a chance of presentation of knee joint pain. Reactive arthritis, there is more chance of knee joint affected. In reactive arthritis, there will be the patient that mnemonic is can't see, can't pee, can't climb a tree. That means conjunctivitis, urethritis, and arthritis is affected. And that is can't see, and that is conjunctivitis, can't pee, urethritis, and can't climb a tree, that is arthritis. And there will be chance of more affection of knee joint in reactive arthritis. There may be a history of enteropathic disease, that means any dysentery or any gastrointestinal infection or any sexual infection. This reactive arthritis is more common in sexually active males. Such infections, after this particular infections as a sequel, there is a chance of reactive arthritis. So just ask the patient in history whether 4 weeks or whether in 6 weeks there may be any gastrointestinal infections or any infections followed after sexual activity. Such things should be ruled out in reactive arthritis. And also in ankylosing spondylitis, as we all know, the pain starts from sacroiliac joint and then it radiates from down to up. The fusion of spine occurs. In that particular condition also, there is a chance of knee joint pain. So please keep in mind the inflammatory monoarticular arthritis. And the last one is mainly psychogenic. Due to this particular condition also, sometimes mainly 30 in between 30 and 45 females are coming as a psychogenic pain with any history. But on clinical examination itself, we can rule out there is no such conditions related to this. Okay, we already discussed these particular conditions. DD of acute monoarthritis. Please keep in mind these structures. Coming to the basic clinical examination of knee joint. Here in this video, we can see the basic clinical examination of knee joint. We can see this. This is the palpation of medial and lateral side of patella. This is helpful in the diagnosis of Chondromalacia patella. Chondromalacia patella. This particular clinical examination is known as Clark test. In Clark test, what we are doing is, with the first web space, in between the thumb and index finger, fix the superior aspect of patella and ask the patient to tight the quadriceps. Whenever the patient tights the quadriceps or contract the quadriceps, due to the pull of this quadriceps, the patella will move proximally or upwards. We are blocking this particular proximal movement of patella with our first web space, which may cause pain. This will be positive in Chondromalacia patella. These are here we can see this is the patellar tendon, lateral joint line, medial joint line. This patellar tendon and medial joint line and lateral joint line is very much palpable in 90-degree flexed knee joint. Sorry. This medial joint line and lateral joint line is painful. This is the point of iliotibial band syndrome. Just 2 centimeter proximal to the lateral joint line. This is patella. That particular point from the medial joint line, proximal to that particular point is attachment of medial collateral ligament, which is more prone to injury. In medial collateral ligament, that femoral attachment is more common site of injury. In osteoarthritis, more commonly medial joint line is affected. In meniscal injury also, medial joint line is affected. Whenever there is lateral meniscal tear, lateral joint line is affected. This is the point of iliotibial band. This is patellar tendon and then tibial tuberosity. This particular area is of a suprapatellar pouch. This is the suprapatellar pouch. To check whether the effusion, we can do this particular clinical examination test. But to check whether there is effusion, we can move the suprapatellar pouch more distally and then just press the patella and then feel the effusion. This is particularly regarding the clinical examination. And this is the grading. I already explained in osteoarthritis. We must all know this grading. So I included this particular X-ray. And here in grade 1, there will be doubtful narrowing of joint space and possible osteophyte lipping. But in this particular condition, no patient will come to OPD. And in grade 2, definite osteophyte. This is osteophyte. And the difference between osteoarthritis and rheumatoid arthritis is, in osteoarthritis, there will be osteophyte formation. And in rheumatoid arthritis, there won't be any osteophyte formation. In osteoarthritis, there will be asymmetric space reduction. In rheumatoid arthritis, there will be symmetric space reduction. And the third thing is, in rheumatoid arthritis, there will be osteoporosis. But in osteoarthritis, there won't be osteoporosis. This is grade 2 X-ray with definite osteophytes and possible narrowing of joint space. Mainly medial joint line is more affected. In grade 2, medial joint line is more affected. Medial joint line space will be, this is medial joint line. This medial joint line space will be less than lateral joint line space in grade 2. And here we can see there is subchondral sclerosis also. This is subchondral sclerosis, which is seen in grade 2. And in grade 3, there will be moderate multiple osteophyte, definite narrowing of joint space and sclerosis and possible deformity of bone ends. And in grade 4, large osteophyte, marked narrowing of joint space. The joint space will be completely affected, mainly medial joint line, with severe sclerosis and definite deformity of bone ends. And after grade 4, there will be more deformity. mainly in osteoarthritis. Whenever there is deformity occurs, then the result of total knee replacement will be less. So it is better to do TKR before the deformity. And this is X-ray. This particular difference is this X-ray which is above is taken without weight bearing, and this X-ray is taken with weight bearing. So definitely, whenever we are advising an X-ray of knee joint, ask the patient to do it in weight bearing. So when we write X-ray, when we prescribe X-ray, right or left or both knee joint, AP standing and lateral. Lateral should be done in non-weight bearing, but AP should be done in weight bearing or standing. So that see the difference here. The space is medial joint space is completely obliterated. That means this is grade 4. But whenever we are taking the same patient's X-ray in non-weight bearing, see the difference. We may miss this prognosis. Why? Because this is actually grade 4, but we read it as grade 2 or grade 3, and this condition, this result will be altered. So definitely ask the patient to do the X-ray in weight bearing. This is the 5 hallmark signs of osteoarthritis. And this is a test for tuck test. This is for osteoarthritis. That means timed up and go test. This we can see this particular test. And this is mainly for osteoarthritis. We are doing this test. Walk a distance of 3 meter. Walk a distance of 3 meter and return to the same place. The normal time taken is 10 seconds. After this class, you can check. The normal time taken is 10 seconds. Walk a distance of 3 meter and return. From sitting position, the patient should start walking. Here we can see that it takes almost 34 seconds. From sitting position, the patient should start walk a distance of 3 meter. And after 4 weeks of management, here we can see the patient walks the same distance of 3 meter with nearly 12 seconds. And that is the difference. From 36 or 34, it is reduced to 12 seconds. And that difference we can assure it won't be normal. Why? Because this is grade 3 osteoarthritis. So we can do this clinical examination. One is clinical examination assessing the range of motion of knee joint, and the second is through palpation we can assess the tenderness, and another clinical examination is tuck test, timed up and go test. And this usage, what is your opinion regarding the usage of this orthosis in osteoarthritis? What is your opinion? You can send message. What is your opinion in the usage? Please send a message as chat. Usage of this orthosis in the management of osteoarthritis. Sometimes patient may use this for very long prolonged period. It may be good or not. Either you shall post good or you shall post bad. Two options, 50% probability. No one is ready to send message. Okay. In the very first phase of management, if the pain is more, that means if it's grade 3, only grade 3, not grade 2. If it's grade 3, that means the patient's pain is more and the patient needs to stand as part of their job and or as part of household activities. If the patient needs to stand, in that condition, it is advisable to use a knee brace. I will show the picture of knee brace. This is not knee brace. A knee brace shall be advised if it's a grade 3 osteoarthritis or grade 3 chondromalacia, patella, and the patient needs to stand for a more time. But if the patient is able to do rest, then in grade 3 also there is no need of orthosis. And the usage of this is not good. Why? Because if the patient is using this, the patient have support of this, and so that there will be muscle wasting. The quadriceps muscle will waste, and in turn, in long run, the patient's osteoarthritis will increase. So it's not good to use these things. If we are advising an orthosis to this patient, then definitely ask the patient to avoid the orthosis after pain relief. This is the change in X-ray of osteoarthritis and rheumatoid arthritis. Here we can see that in osteoarthritis there is asymmetrical space reduction. Please note, in rheumatoid arthritis, if we are taking X-ray, it is very easy to diagnose rheumatoid arthritis. Why? Because there is symmetrical space reduction, but in osteoarthritis there is asymmetrical space reduction. Second thing is that there will be osteoporosis in rheumatoid arthritis. In osteoarthritis, there won't be osteoporosis, but there will be osteophyte formation in osteoarthritis, and in rheumatoid arthritis, osteophyte formation is absent. Three difference. One is osteophyte formation, only seen in osteoarthritis. Second is osteoporosis, only seen in rheumatoid arthritis. Third one is symmetrical space reduction in rheumatoid arthritis and asymmetrical space reduction in osteoarthritis. In osteoarthritis, medial joint line is more affected. And this is the picture of above knee cast, which is advisable in knee joint injuries. Please note the position: 30-degree flexion of knee joint and 90-degree flexion of ankle joint. This is above knee cast. Either we can use a posterior cast from this area up to the metatarsophalangeal joint, or instead of this, we can use a knee immobilizer. This knee immobilizer is equally helpful as above knee cast, but I am using above knee cast than knee immobilizer. This is knee brace, which is advisable in the second phase of injury, and also if there is grade 3 Chondromalacia patella and grade 3 osteoarthritis, and the patient needs to stand more. In grade 4 also this can be used. And coming to the diseases, I think I shall stop here and continue on next day regarding this patellar tendonitis, bursitis, and Chondromalacia patella. I would like to stop this discussion here. If you have any doubt, please send me a message in the chat box. Let's stop here and continue tomorrow. Thank you once again to the organizers for this session. Thank you.
Thank you, doctor. Thank you all.
Free to ask any doubt regarding the topics which we discussed today.
Sir, one asked, what all Ayurveda treatment we can do after anterior cruciate ligament surgery?
After surgery, we only need to do rehabilitation. Actually, after surgery, definitely there will be advice from the physiotherapy department of same hospital regarding the rehabilitation, phases of rehabilitation. And we can add some yoga like Merudandasana, then Trigonasana. Such asanas can also be added along with the rehabilitation physiotherapy. Why? Because this particular physiotherapy along with yoga will give good results. So there is no need of Murivanna. Why? Because the usage of Murivanna is immediately after the injury. I will explain that. Immediately after the injury, there will be Pitta Rakta Koma. In Susruta Chikitsa, Bhakna Chikitsa, and also in Sadhyavarana Chikitsa, second chapter and third chapter, definitely we can see that in all slokas we can see Pagati Pariharartham Sandhanartham Shida Prayogam is advisable. In modern also we can see that immediately after the injury, the protocol advised is PRICE. That means protection, rest, ice, compression, and elevation. As part of ice, Shida Prayoga is advisable. In Susruta Chikitsa, we can see in so many places there is Nugrodadi Shidadara, Shali Pishta Lebana. All these are advisable. Even the spleens advisable are also of Shida Virya. It is also already explained in Dalana Tika. And this Shida is for Pitta Rakta Koma. The complaint occurring there is hematoma formation. This hematoma formation is due to either fracture or due to tear of a ligament or tear of a tendon. And this hematoma formation will definitely causes Shoyadur Bahulyam. In Samani Lakshanam, we can see that Shoyadur Bahulyam, Spandana Vartana Sparshasahishnatam, Aupetiamane Shabdam, Srastangada, Vivida Vedana Pradurbhava, Sarvasu, Avastasu, Na Sharmalabha. Only thing, Avapitiamane Shabdam or grating sensation is due to that fracture. All other things are due to this Pitta Koba and Shoyadur Bahulyam is due to this hematoma formation. Hematoma is not there actually, and this hematoma causes injury to soft tissue injury, and that hematoma is the problem. But this hematoma helps us in two ways. One, it acts as a temporary spleen. Second thing, it helps in the healing phase. And in this particular initial phase, we are using this Murivanna. Murivanna is a Tikshna Virya drugs. Actually, there are 4 Tikshna Virya drugs along with 4 Shida Virya drugs in a medium Shida base, that is Kera is used, and it helps in the initial Pitta Rakta Koba. And after the injury, after surgical management, it is not advisable to use Murivanna. This is my personal opinion with my clinical experience and also along with my guru's opinion. I am trained by Chandrakumar sir, Suresh sir and Matthew sir. But with their opinion also, it is advisable to use Murivanna in the very initial setting, and in the later phase as part of rehabilitation, we can use actually this Ashavanna. Ashavanna is Ayavanna, that is a preparation of this Shantigiri. That such things should be used to avoid stiffness and to avoid this restricted range of motion. We shall use such Ashavanna and Pindadaila for more range of motion if there is stiffness. And regarding the principle of rehabilitation in Ayurveda, we can use 3 things. One is Lebana or Banaha, if there is swelling. Only if there is swelling and stiffness, we are using this Ubanaha or Lebana. We can use Nagaradi as it's an injury, or we can use Jadamayadi, or we can use Ellum Nishadi. Such things can be used. And second phase, if there is restricted range of motion, we can go for Dara to maintain the range of motion. And if there is wasting of muscles of quadriceps, if there is significant wasting after clinical examination, we can go for Shashtiga Leba for muscles. We can use this Shashtiga Leba. It can be used as Sarasa Shashtiga Leba. That means Mamsarasa can be added for Shashtiga Leba if there is muscle wasting. This is the management we are using after anterior cruciate ligament injury. And this ice pack is good immediately after the injury. In the second phase, it is better to go for Ushna Prayoga as per Ayurvedic and as per modern concepts. That particular change from Shida to Ushna, change from a simple injury to large injury, that it may differ according to site, it may differ according to the injury, it may differ according to grade 1, grade 2, it may differ according to fracture. The next question is how we can delay onset of osteoarthritis. To delay onset of osteoarthritis, as we all know, it is a disease of age. It is a disease of wear and tear. If we are using a machine continuously, there will be wear and tear. Same like that, osteoarthritis may occur. To delay osteoarthritis, it is better to start Rasayana after the age of 40. After the age of 40, it is better to use Rasayana after Ashodhana. Then definitely we shall continue the exercise. Exercise is of very much importance to delay the osteoarthritis. We can do regular exercises, and also if at the age of 50, it is advisable to do quadriceps strengthening exercise, quadriceps muscle strengthening exercise. That means quadriceps, which we will discuss tomorrow, that such exercise should be advisable at the age of 50, after the age of 50, if we are doing it definitely. And also other exercise for whole body. And if we are taking regularly this good food as per Ayurvedic concepts, that means if we are taking the food advisable in Ayurveda to use regularly, such things if we are using, then this osteoarthritis can be delayed. This regarding the usage of ice, I already explained. Actually, this in all injury, the injury management principle is reduction, retention, and rehabilitation. That means reduction, that is correction. Retention means immobilization. And this immobilization may differ according to that particular injury. And the last one is rehabilitation. This reduction and retention is not needed in all conditions, but definitely rehabilitation is needed in all conditions. And rehabilitation means we can give simply muscle strengthening exercise. In Hasta Tala Bhakna, in Susruta, it is explained that we can use Mritpindam, Lavanapindam, and Pashanapindam. Mritpinda, Lavanapinda, Pashanapinda usage is just active use and exercise, active use and exercise against resistance, and active use and exercise with weight bearing. This is the principle of rehabilitation. This can be advisable, and this kiri is not needed in all conditions. If that particular condition needed, that means if there is stiffness and if there is restricted range of motion, even after that, then we can use. It is not needed in all conditions. A swelling in knee joint occurred and when kiri was done, pain increased. Why? How can I say that? From the very beginning of this class, I am giving more emphasis on the importance of diagnosis. Without diagnosing, we should not do a single procedure. Without diagnosis, we should not do a single procedure. We can find all the conditions, diagnose all the conditions with clinical examination, and relevant investigations are used to confirm the diagnosis. To confirm the diagnosis, we are using the relevant investigations, but we should stick on the clinical examination. This I can't know what is the reason. How I can say we should do the clinical examination, and with the diagnosis we should do. And please note that this Snigdha Prayoga should not be done first. Definitely we should do Rusha Prayoga in all conditions, but the first thing is diagnosis.